I'll ask the patient to put their hands around the waist. And after that, I'll ask the patient to put their both hands behind the head like this and to kindly lean forward. So with this, kindly lie on your back. We start with the asymptomatic breast. After dividing the breast into 4 quadrants, we can start from the first quadrant, palpating in almost like a spiral motion from the nipple, from nearest to the nipple, proximal to the nipple, going outside. During palpation, we look for masses and any tenderness. Hello, I'm Dr. Stephanie Odogi from Equity Afya KM Center. And today I'll be taking you through breast cancer. October is Breast Cancer Awareness Month. So basically, I want to make the public aware, talk about the importance of screening, and early screening leads to early detection and prompt treatment. So cancer is abnormal growth of normal cells. As breast cancer, you're just having an abnormal growth of the breast cells. So what are some of the risk factors for getting breast cancer? We divide them into modifiable, or those that are changeable, and non-modifiable, those that one cannot change. So modifiable, we have things like smoking. Smoking has a lot of carcinogens, toxins, obesity, fat cells make estrogen, hormone replacement therapy, alcohol consumption. Those are some of the modifiable things that can change when physical inactivity. For the non-modifiable ones, we have a family history of breast cancer. We have gene mutations. We have prior diagnosis of any breast pathology. We also have early menarche. Early menarche predisposes you to a long exposure to estrogens, and late menopause also does the same. And just to mention at least something on modifiable risk factors, you have the oral contraceptive use is also a modifiable risk factor for breast cancer. Not breastfeeding is a risk factor for breast cancer in that during breastfeeding period, there's a hormone called prolactin that promotes milk production, and when prolactin levels are high, estrogen levels are low. So what prolactin does, it reduces the level of estrogen levels, and hence reduced exposure to the estrogens. So those are the risk factors, some of the risk factors for breast cancer. So how does the patient present? We'll get into the symptoms. One, the patient can come with a breast lump, changes to the nipple, either inverted nipples, sometimes a bloody discharge. We can have overlying skin changes. The skin overlying the breast can present with dimpling. Patient can also present with enlargement of the axillary lymph nodes, so they can come with complaint of swelling in the armpit. So those are the signs and symptoms. So when you are taking clinical history, we start with the history taking. We start with the signs and symptoms, and then we go to the diagnosis. So if a patient comes with those complaints, we do what is called a clinical breast examination, and I'll be able to take you through how we do the clinical breast exam. Clinical breast examination starts with exposure, but before that, it's good to gain consent from the patient, explain the procedure, and then start the examination. Ideally, we should have a tummy for the demonstration, but my colleague will help me for today's session. So we'll start with exposure, exposing the breasts completely uncovered. And during exposure, we do inspection. For inspection, we look for any asymmetry of the breasts, any obvious swelling or masses or any skin changes. Kindly stand. I'll ask the patient to put their hands around the waist. This one helps to contract the muscles that are below the breast and help us visualize the breasts well. And after that, I'll ask the patient to put both hands behind the head like this and to kindly lean forward. So with this, if there is any dimpling, we'll be able to see it clearly, just in case we missed it during first time when we were exposing. Thank you. Then kindly lie on your back. Now the patient is lying flat. Then I request the patient to kindly put her hands again behind the head, both hands. And then during examination, we start with the breast that is the asymptomatic breast, or the breast that didn't have any complications. So we divide the breast into 4 quadrants, and then we start palpating. From the first quadrant, we start proximal to the nipple, palpating in like a spiral motion until we palpate the whole breast, and then we also proceed to palpate the axillary tail. So during palpation, we look for any masses and any tenderness. After palpation, I'll palpate if the patient is having the complaints with the other breast or the breast that has the pathology, that is the breast that we proceed with. Do the same, palpate for any masses or tenderness, and if there is any mass, we report the site that the mass is in, the size, the consistency, the margins, whether it is attached to underlying muscles or if there are any overlying skin changes. And then I ask the patient to press on the nipples, both sides, and we look for any discharge. And they press with the thumb and the index finger. So we look for any discharge. So that is how we do the clinical breast examination. So if during clinical breast examination, if there is any mass, we send for further investigation. For patients less than 40 years, we usually recommend ultrasound, though the screening tool for any breast lump is usually mammogram. But because of the exposure to radiation, we want to limit it to 40 for females aged 40 years and above, and for below 40 we do ultrasound. Though for high risk patients, like patients who have a family history of breast cancer, we do the mammogram. Thank you. So after sending the patient for imaging and it is inconclusive, there are other studies that we do, for example, biopsy and histopathology that follow up to confirm a diagnosis and also for staging. So after staging of breast cancer, we proceed to treatment. And treatment is usually determined by the staging. For treatment modalities, we have surgical, we have radiation, and we have chemotherapy. These ones will be determined by the staging of breast cancer. And then from prognosis is usually also determined by the stage. Earlier stages have better prognosis compared to the late stages of breast cancer. And it is important to note that men also develop breast cancer, though it is not as common as it is in women. And for most males, by the time it is discovered, it's usually in the later stages of the disease. And unfortunately, the screening recommendations that we currently have don't recommend screening of breast cancer in males. And then from there, it is good to mention preventive measures for breast cancer. So again, for ease of remembrance, we'll also divide them into those that are related to the modifiable and those that are unrelated to the non-modifiable. So for those related to the modifiable, you can quit smoking and alcohol consumption, physical activity, encouraging breastfeeding in mothers, and also the non-hormonal forms of contraception. For the non-modifiable ones, we recommend early screening for patients who are at risk, like we said, those who have a high family history, who have a family history of breast cancer. Screening of breast cancer is usually put in, I say, grouped into populations. For populations aged 25 to 34 years, after we recommend the clinical breast examination and then the ultrasound, and it can be done if it's negative. We recommend screening in intervals of 1 to 3 years. For population ages of 35 to 39, we also recommend the clinical breast examination and mammogram, or for patient at risk, as I had mentioned earlier, they can go for mammogram. For those not at risk, ultrasound is okay, and this can be done in intervals of 1 to 3 years. For women aged 40 to 45 years, we have the clinical breast exam plus the mammogram, and then an annual screening. And then for ages 56 to 74, mammogram, and then can be done screening can be done every 2 years. For ages 75 and above, the patient discusses with the doctor the utility of screening if necessary. In conclusion, just to reiterate what you had mentioned earlier, breast cancer is the leading cancer in Kenya, and screening is very important for early detection. And with early detection, you have prompt treatment and better prognosis. And also, just a reminder that the clinical breast exam that was demonstrated can also be done at home as a self breast exam. So, just for like it's a self screening or a self breast exam, so that in case anything is noted, the patient can report to hospital early enough. Thank you and have a blessed day.